Okay, thank you for giving us the floor. Good afternoon to everyone. So we're about to present these very interesting data from Cameroon. And these data actually are there to give the outcome of treatment, because the assumption is genotypic resistant testing will best suit or best guide the prescription. But unfortunately, as it is the case in many resource-limited settings, we don't have always access to genotypic-guided switch. So these are there's no conflict of interest to declare. As most of we who may always know, Africa actually carries the heaviest load about as HIV is concerned, HIV epidemic is concerned. But what is most important on this slide, or what we really want to emphasize on, or what really backed up the rationale of this study, was the fact that there is increasing HIV drug resistance in sub-Saharan Africa. And specifically in Cameroon, the prevalence is more around 3%, but we have already documented several cases of acquired drug resistance. And this study by Fokami collaborator some years ago in 2023, we reported up to 92% of acquired drug resistance. And in these settings, unfortunately, patients with acquired drug resistances, they are actually difficult to follow up, and most of them, they are heavily treated. These are patients with more than 10, 11, 12 years of therapy. And as Professor Shapiro said earlier on during the previous talk, not Cameroon, but treatment also should take into consideration the genetic diversity. And unfortunately for us in Cameroon, we have a very, very wide diversity of HIV clades circulating. This is a study down there. I don't know if... Okay. This is a study that we conducted in CRCB in Cameroon last year. The study is still ongoing. And in that study, we analyzed the genetic diversity for the past 33 years. And we realized that there's an increasing trend of the CRF02AG subtype and a declining trend of group O. So with the assumption that personalized strategies will tailor at the selection of best therapies to prevent the emergence of drug resistances or even ameliorate the outcome of the treatment, we carry on this study within a subset of unsuppressed participants. So I'll spare you the details of the sociodemographic and clinical data. But what is important here, as we said, majority of these patients, more than 10 years of treatment. That's the first point. Second point, majority of these patients, we realized that about 62% of them were failing tenofovir, lamivudine, and efavirenz-based therapy, whereas 33% of them were failing PI-based, which was atazanavir, lopinavir, and zidovudine-based therapy. So, as respect to HIV drug resistance profiling at failures, this is at enrollment, we realized that 60% of them were already harboring single drug resistance or even multiple class resistance treatment. About 58 of them resistances to nucleoside reverse transcription inhibitors, about 60% non-nucleoside reverse transcription inhibitor resistances, and 62% PI resistance mutations. So now the outcome, first of all, we realized that more than 92% of the participants actually respected the genotypic resistance guided switch. They respected the protocol that we recommended, but we realized that 64% of them were actually being recommended a PI-based treatment, and 36% were recommended a dolutegravir-based treatment. And we want to emphasize here that the dolutegravir-based regimen was actually in combination with darunavir. And also, with respect to the outcome, we realized that the viral suppression, which is here defined as a viral load less than 1,000 copies, because that's the threshold in our setting, was from 80 to 85%. And here we were looking into the potential drivers of those that virologic response, we realized that only dolutegravir-based prescription was associated to this incredible response. We looked much more into this detail to analyze the dynamic of this response and realized that up to 3 months of the response, we started having some very good response with dolutegravir-based having a very great efficacy over PI-based, and this was still the case till 24 months. Patient at the 3rd year, we realized that there were more or less some the superiority of dolutegravir-based was more or less lost, and the main recommendation here is that heavily treated patients, for them we actually need the selection guided with genotyping, and in the absence or limited access to genotypic resistant testing, dolutegravir-based ads often associated with darunavir should be prioritized. I would like to thank you for your kind attention.
Thank you.